The present electrocardiogram is obtained from a 30-year-old male with history of recurrent episodes of sudden onset palpitation and chest pain. Which of the following is the correct answer? 1. Old inferior MI. 2. Right bundle branch block. 3. Wolff-Parkinson-White syndrome. And 4. Acute high lateral wall ischemia. What are you going to do for this patient? As usual, to interpret every EKG tracing perfectly, use the 10-step approach. First, start with standard values. The EKG speed and voltage are 25 mm per second and 10 mm per millivolt. So, this is a standard and acceptable strip. Next is determining heart rhythm. There are uniform sinus P waves preceding QRS complexes. The QRS complexes are narrow and morphologically identical as well. Additionally, the ratio of P to QRS complex is 1:1. So, there is no dropped beat, and the RR interval, PP interval, and PR interval are stable. Therefore, the underlying rhythm in this strip is normal sinus. The third step is heart rate calculation, since the rhythm is regular, and there are 17 small squares between consecutive R waves, the heart rate is about 88 beats per minute. How about heart axis? QRS complexes are positive in D1 and D2, so the axis is normal. Next thing is examining waves and intervals. P waves are upright in D1, D2 and negative in AVR, so they are sinus. Additionally, the voltage and duration of P waves are 1 and 2 small squares respectively, therefore there is no LA or RA abnormality. The PR interval is 2 small squares and obviously narrow. The QRS complexes are 3 small squares in duration and are wide. There is prominent slurring of the upstroke of QRS complexes that favors delta wave. Other QRS abnormalities are pathologic Q waves in inferior leads and positive concordance in precordial leads. In summary, wide complexes, delta wave, pathologic Q wave and positive concordance are abnormal changes of QRS complexes. The QT interval is about 9 small boxes, so according to the Hodges formula, corrected QT interval or QTC is nearly 410 millisecond. The ninth step in EKG interpretation is examining ST-T wave changes. There are widespread subtle ST depressions in precordial leads, with concomitant isolated T wave inversion in AVL. As we said previously, wide QRS complex of any cause can produce secondary discordant ST-T wave changes. For more information about causes of secondary ST-T wave changes, tap the link in right upper corner. The last thing is overall interpretation. Before going through it, if you've liked this video so far, please subscribe me and ring the bell for further videos. To make a perfect interpretation, we should make a list of abnormal findings. Short PR interval, wide QRS complexes due to delta wave, pathologic Q wave and inferior leads, positive concordance, and secondary discordant ST-T wave changes are abnormal findings in this strip. Remember that, as long as surface electrocardiogram is concerned, the triad of short PR interval, delta wave, and wide QRS complexes makes the diagnosis of Wolff-Parkinson-White or WPW pattern. Other abnormalities including pathologic Q waves are owing to WPW pattern as well. Let's go through WPW and its clinical significance. Wolff-Parkinson-White pattern or WPW EKG results from early depolarization or pre-excitation of the ventricles, due to electrical impulses bypassing the normal conduction system of the heart through an accessory pathway. Abnormal ventricular activation results in morphological changes of QRS complexes. Accessory pathway may be associated with certain supraventricular tachyarrhythmias, including atrioventricular reentrant tachycardia or AVRT and atrial fibrillation. Note that the presence of accessory pathway in asymptomatic patients is called WPW EKG or WPW pattern. while the presence of pre-excitation in surface EKG with symptoms of paroxysmal tachycardia like sudden onset palpitation, chest pain, presyncope and syncope is known as WPW syndrome. In other words, WPW pattern is an electrocardiogram entity, but WPW syndrome is a clinical entity. Cardinal features of pre-excitation include 1. Short PR interval, 2. Delta wave, and 3. QRS prolongation. WPW pattern can mimic a wide range of conductive and structural abnormalities. Discordant ST wave changes such as ST depression and T-wave inversion can mimic ongoing ischemia. Presence of pathologic Q wave can mimic old myocardial infarction. Prominent R wave in V1 may be mistaken for right bundle branch block or right ventricular hypertrophy. Sometimes in WPW EKG, QRS complexes are high voltage and therefore mimic left or right ventricular hypertrophy. That's why WPW pattern is a great masquerader of many abnormalities. As an example, our today's patient has both pathologic Q wave and prominent R in V1 that may be mistaken for old inferior myocardial infarction and RBBB respectively. Thanks for watching this video. If you are interested in challenging EKG cases, subscribe me and ring the bell for next EKG quizzes.